Thank you very much for those who dialed in. If you're using the PDF, you can see the slide numbers up top. I'd first like to acknowledge the co-authors on this paper, Bonnie Levine, Hilary Snapp, Jim Bustruck, and Carrie Balaban. On the next slide, slide 2, you'll see the affiliations. The group was from the University of Miami and the University of Pittsburgh. On the next slide, slide 3, is our disclosure. There are no conflicts of interest or financial interest to report. So on slide 4, this issue began for me when I got a call from the State Department in February of 2017, and literally the call was, "This is the State Department, we have a problem." They spoke to me about individuals who began experiencing symptoms late in 2016 with ear pain, ringing in the ear, dizziness, and cognitive issues. All of these individuals had experienced a loud noise or pressure phenomenon before and during the symptoms. All were members or family members of individuals stationed with the U.S. diplomatic mission in Havana, Cuba, and the sound was localized and followed the individuals from room to room. If they moved in the room, it would move, and if they opened the front door, the sound would go away. Next slide, slide 5. So at the University of Miami, we had the opportunity to look at these individuals. And we saw 35 individuals at the University of Miami. 25 had exposure and were symptomatic. 10 individuals did not have an exposure, but lived and were in the same house as an individual who was exposed at the same time they were exposed. So they were in the next room and they didn't get an exposure, they didn't have any symptoms. It's important to point out that all of the affected individuals were affected either at their domicile or in a hotel room, not at work. We then went down to Cuba and evaluated 105 unaffected embassy members. Those were largely selected for us by the embassy mission, except for a group of U.S. Marines to protect the embassy. We requested to see them ourselves due to my 21 years of active duty service. On the next slide, slide 6, basically what we did a standard history and physical exam with targeted neurologic exams. We looked at eye movements to include nystagmus, mood pursuit, saccade and anti-saccade, optokinetic response, invergence response. We did standard audiometry. We did additional vestibular and neuropsychological testing as necessary. This is a retrospective review of individuals that we were seeing clinically. So we only could do tests on these individuals that were supported by the clinical picture, which you can see now in that statement on the beginning of slide 7. Only clinically relevant data was collected. Now, importantly, the individuals were acute. They were unaffected by the influences of time. They did not have any pre-treatment modalities. They were not here for compensation concerns, and there was no media attention given to what was happening in Cuba when we saw these individuals. It's an important point because now that there's been media attention surrounding this is the only group of individuals who were, in a sense, pure that really can be collected. In the future, unfortunately, we're going to have to face the fact that next groups of individuals will know what they're supposed to feel. These individuals did not. Slide 8, the population studied on the chart there, as described earlier. Now, slide 9 shows you the presenting symptoms of the individuals. The affected group is the 25 individuals we evaluated at Miami who were affected by the sound and had symptoms. The unaffected were individuals, again, from the same household at the same time, but without symptoms. And so you can see that other than headaches, which is unfortunately a very common symptom throughout the world, there's 0% of symptoms for the unaffected, and a large percentage of the affected had symptoms of dizziness, cognitive disorders, hearing loss, ringing in the ear, and 96% of these individuals had at least 2 symptoms, and 64% had at least 3 symptoms. Even if you take headache out of the equation, 96% of the affected individuals had 2 symptoms, and 56 had 3 symptoms. Again, dizziness, cognitive disorders, hearing loss, ringing in the ear pain, and headache. Next slide, slide 8, shows you the data that we obtained in Miami. Now, I'm going to tell you that, or slide 10, I apologize. I'm going to tell you that this data is all going to be coming out in more detail in a peer-reviewed publication. That peer-reviewed publication is due out probably in the next 3 to 4 weeks. I'm showing you some of the data from that, but not enough data that the journal embargo will still hold. So any more detail you can get from that paper. But notice that what we're showing here is that individuals had a high degree of subjective visual vertical abnormalities, of a high degree of head impulse abnormalities, see 83% down there, and a high degree of having at least one vestibular evoked myogenic potential. There are 2 types. One is measured in the neck, one is measured in the eye, and 92% had at least one of those as abnormal. If you go on to slide 11, we'll explain what those are. So subjective visual vertical and vestibular evoked myogenic potentials are tests of the otolithic symptom. So they're indicative of abnormal function of either the utricle or the saccule, which are the body's gravity organs. When you have an abnormality in the gravity organs, you dedicate a lot of mental energy and a lot of attention to staying upright. Because if your sort of sense of what a straight up and down is off, you're going to spend a lot of time keeping your body in an upright position and a lot of energy. That results in less energy available for cognitive tasks and increasing fatigue. And those can be seen in individuals without vestibular pathology. But it's important to note, and I'll show you on the next slide, that we did not call our patients abnormal unless they were far more abnormal than just abnormal in a clinical sense. And that amount of abnormality would only be seen with a vestibular pathology. Note, 100% of the affected individuals, all of them, had abnormalities to their gravity organ. And the 83% that had head rotation abnormalities indicates that the inner ear balance organs, semicircular canals, were also affected. The next slide, slide 12, shows you the abnormal definitions. I'm not going to belabor that. All I'm going to point out is that we were not taking what we typically call abnormal in our clinical lab. We are putting much more stringent characteristics on this. So those who may argue, well, lots of people who are abnormal who have other disorders have abnormalities, they don't have them to this extent. This level of abnormality, as you see at the bottom of the slide, is not seen unless you actually have a vestibular pathology. There were also some cognitive and neuropsychological stuff done by our fine colleague up in neuropsychology, Bonnie Levin. They had complaints of cognitive fog, inattention, problems retrieving information, and increased irritability. They were below the expected level of verbal fluency, working memory, and sustained attention. They had difficulty with auditory processing and difficulty with increasing levels of cognitive load. The exposure is unknown to date exactly what's causing it. It could be ultrasonic, it could be microwave, it could be a variety of other things. Future discussants in today's presentation will present a little more about this. We know that directed energy of some sort can produce cavitation bubbles, and that bubble formation and bursting can produce damage, and candidate spaces exist in the area of the vestibular end organs exactly where we're seeing the abnormalities. So where we described the abnormalities earlier, that's a place where cavitation can form in the inner ear, and Dr. Giordano will detail that a little bit in his talk as well. Is this mild traumatic brain injury? We get asked all the time, is this mild traumatic brain injury? Well, we have a definition of mild traumatic brain injury established by the military several years ago. And the findings don't match. The definitions of mild traumatic brain injury as defined by the military does not fit these individuals. When you look at objective tests, we described and have published that anti- and predictive saccades and head thrust abnormalities are seen in MTBI. whereas these individuals had otolithic abnormalities on the same test device that showed the other abnormalities in MTBI. There's a high incidence of headaches in mild traumatic brain injury and a very low incidence of headaches in this case. And there's differences in the neuropsychological test outcomes. So, certainly the brain or the areas of the brain can be injured, but it doesn't fit the sort of military differentiation of MTBI as we've been using over the last 10 years. Now, what is this? It's probably an acquired neurosensory dysfunction with essentially universal otolithic disorders, with some additional vestibular disorders, and a unique pattern of cognitive findings. It's important to note that that site of injury could be limited to the inner ear, because when you have, as I described earlier, the otolithic abnormalities, the difficulty with staying upright, and the dramatic attention your body will pay to staying upright, you can get secondary cognitive effects without having any actual damage in the cognitive region. But of course, there could be damage in that area as well. The most important thing to note is that for those who are truly affected, they really had a physical injury in and around the inner ear at least. But the findings that we presented, and that we presented in more detail in the paper, which will, by the way, be published in an open access forum. When the paper comes out, anyone in the world will be able to pull up the URL, and any of those on the talk will be able to pull up the URL and read exactly what we're talking about. These findings suggest the ability to screen potential individuals. We can design quick otolithic tests that are easy to transport and quick to perform. We can design a quick cognitive screen, which could be easily designed and easy to perform. Now, screening techniques are critically important to distinguish the worried well from those who are truly affected. And this is really important because we've already seen a couple dozen individuals who complain of, hey, I was an affected individual. And we were able to easily screen them out and determine that they were more worried well. It's really important that any current or future evaluation of cases should include at least these short batteries as a screening mechanism, and the tests we describe in our paper as part of the definitive workup. We'd like to thank a number of individuals, Kurt Yankaskis from the Office of Naval Research, my bosses in my department who allow me to do this kind of work, Danny Font, my administrative assistant, who scheduled all of these patients, Constanza Pelosa and Aaron Williams, who helped with the research, and the nurses and audiologists and support staff at the Miami Ear Institute. We saw these people, literally, they would call, they'd get in within a couple of days, people had to rearrange schedules. They did a wonderful job, and I couldn't do my work without them. Thank you very much.